and in French. Please find the globe at the bottom of your screen and choose your preferred language. Good morning and good afternoon, everyone. My name is Crystal Lander, and I'm the Chief Strategic Engagement Officer for Pathfinder International, an organization dedicated to improving the quality, access, and affordability of sexual and reproductive health services for women and youth around the world. Yesterday was Universal Health Coverage Day, which is an annual rallying point for advocates to raise their voices and share the stories of millions of people still wanting and waiting for access to healthcare in the communities where they live. It also serves as a call for leaders to make smarter investments in health within their local and national budgets. While many countries are already making progress toward universal health coverage, COVID-19 and the full pandemic has had a great impact on all health systems, including health workforce and access to commodities, setting many countries back quite a bit. Moving towards UHC requires strengthening health systems at all levels in all countries. Now, the bulk of the responsibility for choosing UHC lies within the health systems within countries themselves. Yet, to achieve UHC requires a multi-sectoral approach within and beyond the health sector. Within the health sector, countries will need to strengthen all aspects of their health system, including health workforce, infrastructure, information systems, governance, the supply chain, finance, and service delivery. This is all necessary to meet the evolving health needs of their populations. And health financing is particularly relevant to UHC. If countries are to finance healthcare for all, they must protect individuals and households from undue financial hardship. If we are to prevent future pandemics and achieve health and well-being for all by 2030, we must prioritize equity. Investing more in health and allocating resources efficiently and equitably are always in need. In addition, we must acknowledge coverage doesn't always mean care. Government-sponsored coverage may not allow youth and women to actually access care, and that is something that we must not forget in our advocacy and planning efforts. The focus of this webinar today is to discuss the importance and role of multi-sectoral partnerships in achieving UHC in low and middle income countries, as well as for countries to share experience on the progress they're making toward UHC. We are delighted to welcome Mr. Mohammad Abdus Salam Khan, who's the Joint Secretary for Medical Education and Family Welfare for the Ministry of Health and Family Welfare in Bangladesh, to give us greetings this morning and share his direct experience. Mr. Salam has a distinguished career of over 18 years in the public health sector. He's gone from approving, monitoring, and supervising projects for adolescent health and gender, as well as supporting universal health coverage plans, non-communicable and communicable disease work, maternal health, and sexual and reproductive health. Mr. Salam was involved in the development of 3 sector programs through the Ministry of Health and Family Welfare in Bangladesh. And he's involved in the World Bank project on demand-side financing for maternal health vouchers. Please join me in welcoming Mr. Salam.
Thank you, Crystal Lander. Good morning, good afternoon, and good evening to everyone. And happy Universal Health Coverage Day to everyone. Let me share the presentation. Here we go. Can you see my presentation?
Yes.
Thank you. As you all know, that the universal health coverage second WHO is everyone, everywhere will receive the health care, quality health care definitely, the need wherever they are without incurring financial hardship. And we have 3-dimensional WHO cube that actually indicates who is covered, what type of services also covered, how much money that the client has to pay for that one. And universal coverage is very much a part of the Sustainable Development Goal 3, target number 3.8, and it has two indicators. One is the service coverage, and the other one is the financial hardship, the catastrophic health expenditures. WHO, with the support of World Bank, has developed a framework to track the progress of the USC enable health coverage, and in terms of the services, which has four categories of indicators, and also the catastrophic health expenditure. And in terms of the four categories of indicators, we have seen the progress. Family planning coverage 73%, pregnancy and delivery care 36%, child immunization 97%, care-seeking behavior is 42%. Tuberculosis 63%, and we have done very well on malaria prevention 100%, access to basic sanitation 47%. In terms of non-communicable disease, the prevalence of normal glucose levels 83%, blood pressure 75%, those are normal, and tobacco non-use 65%. In terms of the health system strengthening, that's 43% of density of hospital beds. Health worker density is only 9%, access to essential medicine 65%, health security is 58%. In terms of key indicator progress, coverage essential service index is 56%, but the catastrophic health expenditure is 24.7%, which is very large. Government has taken initiatives to address those issues to achieve universal health coverage, mainly focusing on the primary health care at the grassroots level. The government has actually established a well-structured primary healthcare service delivery arrangements, which we call community clinics at the doorstep of especially those who are poor and vulnerable, to make sure that everyone will receive the healthcare they need whenever they need it. And we also developed the essential health service package in 1998, and we have been using it for all three sectors since then. Currently, we're implementing the fourth sector program, and we are using that ESP, and that is actually updated, composing of the indicators: maternal, neonatal child, adolescent health, family planning, communicable, non-communicable disease, management of common conditions, other support services, for example, lab, radiology, and others. As I said, the community clinics, the nationwide established is a flagship program for the government, and it has actually, each of the CCs covers the catchment area population 6,000. So that is about 14,000 community clinics at the grassroots level. And in that CC, all services, including the medicines, are free. And most of the clients are basically poor and vulnerable women. And we have, as I said, established, prepared the essential service package for each of the facilities, for example, including through CC to Union Health Family Welfare Center, Ubja Health Complex, Maternal Child Welfare Center, up to district level hospitals. And we have been implementing the sector program since 1998. Currently, we are implementing fourth sector program from started 2017 until 2022, and the transformation of the health systems towards USC and SDGs. And we're also planning to prepare and implement the fifth SWAP sector-wide approach. Will start 2022 until 27. That will incorporate the lesson learned from the previous sectors, especially fourth sector, and accelerate the progress towards the USC. And for the sixth SWAP, we'll actually, USC and SDG will be achieved by the year 2030. And we also have policy support. There are a lot of policies that we adopted. We prepared, starting from National Health Policy, Bangladesh Population Policy, National Nutrition Policy, 8th Five-Year Plan, and Healthcare Finance Strategy, and also the Gender Equity Strategy. All policies actually are supporting the EUAC. And we also have other other policy directions, for example, the strengthening of the governance stewardship, provision of sustainable financing for the equitable access, availability of quality health workforce, and also the improvement of the equitable access to and the utilization of quality health services to everyone. We also are implementing demand-side financing programs, for example, Shastra Shuraka Karmashosi, Maternal Health Baswari Scheme, and there are other two schemes that has been planned to start piloting health protection schemes for the ready-made garments workers and civil servants. But still there are challenges. Key challenges are inadequate funding for the whole health systems. According to the WHO, we need to invest 4 to 5% of GDP. Currently, we're investing less than 1%. But the problem is also lies in the using of that resources, basically due to the capacity building of the health, the managers of the health at district and the national level. And we also have high out-of-pocket expenditure, and there is a quality of issues. And also the problem is shortage of human resources, lack of training, skill mix, imbalance is also existing in the health sector. And the way forward is basically to increase the governance, improve the governance stewardship role, and also to increase the financial allocation from the Ministry of Finance, strengthening primary healthcare, and also to prepare the healthcare systems so that it will make them happy. All the health systems, the facility will be ready for everyone. So to make sure the health supplies are there. And also we also need to improve the public financial management in terms of reducing the weakness and resulting from dual budgets, and also implement needs and performance-based allocation formula for the budget, and improve the capacity of health managers, reduce the delay of the development fund releasing, and there are other issues that we need to improve. We also need to targeting who are really vulnerable, especially through health protection scheme. And urban health also are neglected in our country, because the help to provide health service in the urban area is basically lying under the purview of the local government, but still we're working with them and try to provide all services to the people who are living in the urban settings. Thank you very much.
Thank you. Now I'll turn it over to my colleague, Dr. Habeeb Salami.
Thanks so much, Crystal. I think that was a very powerful keynote address there from Bangladesh. So we'll move now over to the next session, which is colleagues from Pathfinder country offices sharing their experience on how Pathfinder has been supporting governments in their different countries with respect to achieving universal health coverage. And with me on this panel, Drs. Amina Dorayi from Pathfinder Nigeria. She's the country director for Pathfinder Nigeria. And Dr. Mengistu Asnake, who is the senior country director for Pathfinder Ethiopia. They are both experienced public health physicians, and I think more about them will be shared in the chat box. So please help welcome Drs. Amina and Mengistu. Yeah, so I know that both Pathfinder in Nigeria and Ethiopia been working there for over 40 years, and we've been supporting the health system for that longer time. So can you share with us, with this experience that you have in country, how you have been contributing as Pathfinder in both countries, how you've been contributing to achieving universal health coverage in your respective country? I'll start with you, Dr. Amina.
Thank you very much, Dr. Habeeb. Good morning, good afternoon, and good evening. Thanks for joining us in this important webinar. So I would like to first start with giving a background of universal health coverage in Nigeria. And it's clear that despite consistent efforts by government and all partners in Nigeria, we continue to have poor health indicators, and majority of these health indicators really fall below national and international targets. And the challenge is even that most of these indicators are caused by preventable illnesses. And if the primary healthcare level is strengthened, we would really have a better health system in country. So in Nigeria, we have a National Health Act, which is one of the most innovative reforms within the health sector. It also provides a legal framework for the organization of primary health services. And also more importantly, it guarantees that every citizen has a right to a minimum basic package of care. And this National Health Act, which was established in 2014, provides a very valuable opportunity to address most of our health financing challenges and also promote equitable service utilization. It also earmarks 1% of the consolidated federal revenue for what we call a basic healthcare provision fund. And this fund is designed to be a sustainable model for ensuring equity and financial risk protection, especially for vulnerable groups, by guaranteeing access to a basic minimum package of health services. So this basic healthcare provision fund through the National Health Act is actually Nigeria's roadmap towards achieving universal health coverage. But we have some challenges at the country level, and one of which is at the policy level. So we have a very centralized policy formulation system, but implementation is at the state level. And then the lack of knowledge and full awareness of the funding mechanism among stakeholders is quite much. There's poor accountability for the
Hello, can you hear me?
Yes.
Oh, all right. I think we just lost Dr. Amina there. So while we wait for her to get reconnected, Dr. Menge, can you tell us what Pathfinder has been doing in supporting the government of Ethiopia in achieving UHC? Thank you.
Thank you, Dr. Habeeb, and also thank you for the organizers for this important session. Probably for some of you who might not be knowing Pathfinder in Ethiopia, historically started its link in the 1960s when we supported the first family planning clinic, later which developed to the Family Guidance Association of Ethiopia, which is the IPPF affiliate National Family Planning Association. Since 1995, we started implementation in Ethiopia by primarily partnering with the Ministry of Health and several civil societies and community-based organizations. During this period, we have observed a number of positive changes that include a 5-fold increase in the use of family planning services from the early 1990s of less than 10% to over 41% today. I think this 5-fold increase can be attributed to the overall development of the country, including investment in education, in particular for girls, and the education, the reduction in early marriage, as well as the adoption and implementation of several enabling health and social sector policies and strategies. During all these years, we have worked with over 100 local civil society and community-based non-governmental organizations through different sub-grant mechanisms, which helped in building local capacity and ownership. Currently, our activities are being done in 6 of the big regions in the country, reaching close to 412 districts with a geographical area of inhabiting almost 57 million people. Though this activity in partnership with the government of Ethiopia and other non-governmental organizations, we are supporting, through this activity, we are supporting the expansion of critical health services at the facility, community, and household levels to that mothers, children, families can access care they need. Coming to the universal health care, in achieving the universal health care, creating wide spread access to comprehensive, high quality health services and financial risk protection are very essential. For Ethiopia, to mention some of the 3 important priorities, first of all, defining Ethiopia's essential health service package and identifying prioritized health interventions is an important area where we as Pathfinder are participating from the national level development of strategies, guidelines, and other directives which are very important in improving the essential health services and the different packages to be available at different levels of the health system. Again, another important area with the universal health coverage is the exemption of cost sharing of high priority interventions, and expansion of community-based health insurance programs is a very important one. I would like to come back to this one a little bit later. The third one is the integration of health services within other health sectors, from the national to the district level, to address social determinants of health and establishing emergency preparedness and response units at national and regional levels. Just to see how our involvement in these different issues, I'll try to give you a few examples from our program implementation. First of all, we are a pioneer in terms of the use of community volunteers in increasing access to contraceptives and other reproductive health services at remote villages where the fixed health facilities were not able to reach those with unmet need. Community-based family planning programs implemented by international and local non-governmental organizations through community volunteers in the late 90s and early 2000s laid the foundation to expanding access to family planning information, counseling, and service in Ethiopia. The experience gained through this community-based family planning programs fortunately led to probably the well-known flagship program of the Health Extension Program Genesis, which basically brought health service to the last miles rather than people traveling long distances to get health services. And that has contributed in terms of accelerated achievements of the Millennium Development Goals, which also is currently contributing to the achievement in the Sustainable Development Goals. The HEP was instrumental in increasing the uptake of, when I say the last miles, people who are looking for example, in terms of long-acting contraceptives, they have to travel long distances. With the health extension program, it became an opportunity to introduce long-acting family planning programs at the village level, which really, first of all, increase access, but in terms of the quality of service also, it gives the opportunity to have more method choices at the village level. Another example is reaching the underserved semi-nomadic communities in the different parts of the country through what we call it the integrated periodic outreach services, or briefly IPOS, where The IPOS, or the Integrated Periodic Outreach Service, was originally designed to increase access to vaccination in those hard-to-reach communities. But through our program, we included additional services, such as maternal and child health service that includes contraception, nutrition, treatment of sick children, and antenatal care for pregnant women through that periodic outreach services, which increases the coverage, but at the same time reaching those people and really contributing to decreasing the morbidity and mortality in the absence of services. Another critical area in preventing maternal and child deaths in line with the universal health coverage is the building of strong health system and expanding access to healthcare to help save lives. Strong health systems must be people-centered, and all our activities respond to the actual needs and situations of the people they serve. Pathfinder engages individuals and communities as participants and beneficiaries to identify and resolve problems that impact their health. Through our community engagement activities, we have been able to motivate people to invest in and use primary healthcare services. One aspect of this work has been expansion of community-based health insurance. Prior to the introduction of community-based insurance in 2011, Ethiopia has made a decision in terms of its healthcare financing policy where every government facility should retain their revenue and use it for improving the quality of services. Basically, 70 to 80% will go to purchase of essential drugs and other essential commodities useful for improving the services. And the remaining 20 to 30% can go to other quality improvement activities, including change in the flow of facility or other important things which can make. So the community-based health insurance as one of the financial risk protection was introduced in 2011. So it's a form of health financing offered to households. As I've already mentioned, as a priority critical issues, the financing part is an important area. And those that choose to participate, I mean, it's a voluntary basis, and those that choose to participate make annual payments in a pool of community funds used to offset the cost of healthcare. Whoever is paying into the insurance can access healthcare and so can any member of that person's household. The community-based health insurance is partially subsidized and covers various essential health services, outpatient, inpatient service, surgeries, laboratory, and imaging services, prescribed drugs, dispensing of common illness, and care for childhood illnesses. That would otherwise be paid for by out-of-pocket spending. And looking at the CBHI, it's not only important to the community, but also the overall health system. The community-based health insurance increases health service utilization, creates more predictable and sustainable financing for health facilities, and empowers women. If we look at the crucial things to communities in these services in the community-based health insurance, I think it encourages people to seek out healthcare since there is no need to worry about payment once you are enrolled. They don't need to go to every time they are sick or have some problem to sell assets or other financial risks. It shields women and children from catastrophic out-of-pocket costs and guarantees that family members get services for a subsidized cost. And other areas, it strengthens community feedback to the health facilities and self-care providers, which creates a sort of a social accountability between the community and the facilities they serve.
Dr. Mengistu?
Yes, I'm finalizing.
Okay, please.
Okay.
I know there's so much you'd like to talk about. Go ahead.
To date, over 90% of the districts where we support are being served on these activities. So we continue to support especially those three priority areas in terms of creating the essential health services, the financial risk and also integrating services with others. A very good example is our youth program, where in our youth program, we involve the education sector, the finance sector, local leaders, the health sector, even including religious leaders to be part of this a multi-sectoral approach in terms of improving the health and well-being of the youth in those places we work. Probably let me stop here, and Dr. Amina can add more things from the Nigeria side.
Thank you so much. Thank you so much. I know there's so much that Pathfinder in Ethiopia has been doing to support government. And I actually remember some time ago that the Nigeria office, Pathfinder in Nigeria, had to take one of our reproductive health managers in one of the states in Nigeria on a study tour of the health extension worker program in Ethiopia. It really was a flagship program. Yeah, so Dr. Amina, yeah, welcome back. You lost you briefly. So let's give you an opportunity to complete your thoughts while you were on, and then we'll see if we have a little more time to kind of go around one more time in a second round of questions. Over to you.
Thank you very much, and apologies for the network issues. How would I know I'm in Nigeria? Anyway, so I think I'll just go straight to discussing some of the actions that Pathfinder is taking currently, and also some of the history of what we have done so far in trying to support Nigeria to achieve universal health coverage. For me, I'd like to look at it in three key actions towards universal health coverage. And one is improving financial access, because we know the importance of access to finances for universal health coverage. And the second one is through improving physical access to health facilities. And then I'll also look a little bit of improving quality of the health services. And I know my colleague, Dr. Mengistu, has also highlighted quite a few of what Pathfinder in Ethiopia is implementing. So at Pathfinder Nigeria, in our bid to support the government to improve financial access towards universal health coverage, one of the things we do is that through our advocacy initiative, which is in collaboration with the Johns Hopkins University, BMGF funded project called the Advanced Family Planning. Specifically, we have worked very closely with the governments at the national and subnational levels, civil society organizations, the media, and also communities. One of the things that we have done is to strengthen capacity of civil society organizations, including the media, to even understand what the universal health coverage agenda in Nigeria is, and also the basic healthcare provision fund. What does it mean? How should it be implemented? And what role can civil society organizations play in implementing the basic healthcare provision fund? So we also built capacity of what we call local advocates through advocacy working groups. We build their capacity on budget and policy advocacy so that they will understand the budget process and how the policies are going, and so that they can also provide decision makers with the evidence that healthcare, especially in this case, sexual and reproductive health and family planning, is also a sound investment for both individuals, communities, and also our nation. And it is also part of the universal healthcare coverage towards attaining the UN Sustainable Development Goals. As part of that, also, we work with the advocates or civil society organizations to also follow the money or advocate for the release of the funds to implement the basic healthcare provision fund, and also strengthen accountability mechanisms so that CSOs can demand accountability from the government. In the second key action of improving physical access, I would give some example of a project that was funded by USAID and MSD for Mothers in Cross River State, which we are also implementing a similar project in Kaduna State of Nigeria. And this is called Saving Mothers Giving Life Initiative. And in this case, we support the governments and the private sector to address what we call the 3 delays that act as barriers to timely care for mothers and newborns. And these barriers contribute to the high maternal and newborn mortality that we have in country. And these delays are, the first one is delay in seeking care, and the second delay is delay in reaching an adequate health facility to receive the care, while the third delay is delay in receiving quality care at the health facilities. So what we do to address this first delay, which is delay in seeking care, is that we support the community members, their ability to actually recognize emergencies and encourage health facility utilization. So we also have village health workers and community-based health workers that are in existence in the country. So we train them to be able to recognize danger signs and encourage referrals to health facilities. We also work with our partner, NIVI, to provide on-demand and actionable health information that enables every individual to make informed and supported decisions about their health through especially the antenatal care visits that they come to health facilities. For the second delay in reaching health facilities, we also work with the Union of Transport Workers in the country to see how they can provide transportation facilities free for the communities at the time of care, especially for emergency services. And then coming to the third delay is delay in improving, in getting quality health services. So I would want to say a bit about what we do to support the Nigerian government, both the private and public sector, to improve quality of services. One is that we train healthcare workers in different areas of key health services, maternal health, newborn health, family planning, reproductive health in general, in both public and private sectors, so that health workers can be able to provide those quality of care. Then we also work with the government to strengthen existing systems for supportive supervision and monitoring of quality health provision. One of the things we have also done is to support some facilities that we work with to implement the maternal and perinatal death surveillance and response, so that every mortality is appropriately reviewed and future occurrence is prevented. We support health facilities through a stepwise quality improvement program with Farm Access Foundation in one of our states to deliver safe and quality secured healthcare to patients so that health facilities are able to measure and improve their quality in a safe and efficient manner through a stepwise approach. We also then train health facility staff to improve data management, because without understanding the statistics and the data, we will not be able to have our decision makers make informed choices, both about the financing and the delivery of care. So what we have found out through our work at Pathfinder over the years is that obviously universal health coverage can save a lot of lives. And there's an opportunity through the Nigerian government's Basic Healthcare Provision Fund to reach as many people as possible. But there's a lot need to be done in terms of advocacy. That is why we are working so hard to continue advocating to decision makers and all Nigerians actually to understand and be fully involved in the interventions to achieve universal health coverage. And we also believe that governments at all levels need to improve health infrastructure and equipment so that we can get more value for the money and more improved efficiency of the health services so that our population can trust the care that they can provide. Thank you. Over to you, Dr. Habeeb.
Thank you very much, just at the nick of time. Yeah, thanks, Dr. Amina and Dr. Mengi. You have shared with us innovative high-impact practices in the area of family planning, maternal and newborn health, and adolescent and youth demand creation and services, as well as policy and advocacy, which is significant support from Pathfinder in both your countries. So lastly, just 1 minute each, how do you think your primary health care system in your countries, being the platform upon which where governments are trying to achieve UHC, how do you think they are ready to be able to really drive us and get us to achieving UHC? 1 minute each. Dr. Mengi.
Thank you, Dr. Habeeb. This is a great question. First of all, prior to the SDG era, Ethiopia has taken the initiative of which I said earlier, for example, the health extension program to change the health service tier in terms of, we had a 6-tier system, we changed it into a 4. Now currently we have a 3-tier system, basically, which says a primary level care, a secondary, and a tertiary. So this arrangement is very helpful beyond, I mean, this is the healthcare services, but when it comes to the leadership and others, then there is a decentralized leadership, which is also very helpful in terms of making the primary healthcare implementation a practical one. So the structure is there. We feel that there might be a need to strengthen it, which as Pathfinder, through our donors like USAID, the Bill and Melinda Gates Foundation, we are working toward strengthening these different levels of primary healthcare support. So structure is there. At the same time, the other issue which is there is like access is being achieved a lot, but in line with that, when we talk about essential health services, the quality of care is a very important thing which needs to be strengthened further. Thank you.
Thank you very much. Dr. Amina?
Yes, thank you very much for that question. I think for Nigeria, we, as I said, we have a lot of policies, and one of the things is implementing these policies is very critical. And one of these policies is the primary healthcare under one roof that we have. And this is a concept of bringing all primary healthcare services, in an integrated approach using the principles of one management, one plan, and one monitoring and evaluation. And if we are able to implement this primary healthcare under one roof, and we're also able to ensure that the basic healthcare provision fund is implemented effectively, I think that is one thing that will make us get to universal health coverage. We can also look at the 3 key areas of quality, that is the structure, the process, and the outcome. In terms of structure, we need to ensure that our primary healthcare centers have, the basic minimum package in terms of infrastructure, the buildings, the equipment, and whatever they need, commodities, to be able to provide services. And then for the processes, there need to be a standard of care anywhere that the population goes to, either it is primary or secondary or tertiary, or even private sector. So if we're able to incorporate the private sector effectively in our health system, we would also be at getting towards universal health coverage. And then the last one is the outcome. And our data management has to be strengthened in order for us to be able to see how our outcomes of care are really aligned with the inputs, that is the resources that we provide to improve healthcare. So I think I'll leave it at that. These are some of the thoughts that I think we could go towards improving our primary healthcare system in the country. Thank you.
Thank you. Thank you very much. That's been very wonderful. Yeah, I know there's still a lot that we do to support governments in different countries. Unfortunately, we don't have much time to continue to share. For participants online, please follow up with Drs. Amina and Menge through the Pathfinder website or different countries. There are more they can share with you in terms of how Pathfinder is supporting universal health coverage in our countries. Thank you again, both of you, and we hope to have more opportunities to continue to share the good work that we do. So at this time, I will hand over to Dr. Tabinda Sarosh from our Pakistan office, country director, to moderate the next session. Thank you. Over.
Thank you so much, Habeeb. Could somebody from the team confirm if you could hear me right now?
Yes.
Loud and clear.
Perfect. And what exciting conversations did we just have? I mean, we heard about how Bangladesh is on a very exciting and ambitious journey towards universal health coverage, and then 2 very inspiring talks, from our leaders in Ethiopia and Nigeria. And I think one message that stands out is that universal health coverage, its time has come, but at the same time, we also need to think about access. So wonderful. I'm going to be, and I'm so excited about this, I'm going to be moderating a panel with the various public health practitioners from governments of different countries, as well as the private sector and CSOs. And this is going to be a 40-minute session. After the session, we are going to have questions and answers, which I would be honored to moderate for you. So coming to my session, we want to be discussing the role of multi-sectoral partnerships in achieving the universal health coverage. We are all a closely knit community, an ecosystem which is working together, not just within health, but outside health to see the connections. And when we look at the tracer indicators for universal health coverage, we see connections with so many other sectors which traditionally need to be, which now innovatively need to be a part of our work. Many countries are making progress towards universal health coverage, despite the challenges which have been posed by COVID-19 pandemic. They have impacted on the ability of the health systems to provide undisrupted health services. However, our work must go on. Universal health coverage requires strengthening of the health systems in all countries. Robust financing structures are the key. When people have to pay most of the cost for health services out of their own pockets, then the poor are the ones who get affected. They're the ones who become more vulnerable. And even the rich may be exposed to financial hardship in the event of severe or long-term illness. UHC emphasizes not only what services are covered, but also how they're funded, managed, and delivered. The role of other sectors, public-private partnerships in ensuring universal health coverage cannot be overemphasized, particularly in the context of climate change. And here I would like to introduce my first panelist. I'm going to be giving a brief introduction, and his detailed introduction will be pasted in the chat box. So please keep looking for those details. Dr. Pierre Yaego, I hope you're online and if you can hear me. Thank you so much. I can see you now. Dr. Pierre is the Technical Secretary of One Health and Universal Health Coverage, Cabinet of the Minister of Health, Burkina Faso. Sir, we are honored to have you in this conversation, and we would like you to talk a little bit about how the COVID-19 pandemic has impacted the availability and ability of health systems, and what strategies now the government of Burkina Faso has put in to ensure universal health coverage, and what are the multi-sectoral aspects of the platforms that are in place to deliver universal health coverage. Thank you, sir.
Thank you, everybody. I will speak in French because my English level is not very high. So, pour ce qui concerne le Burkina Faso, je dois préciser que pour l'atteinte de la couverture santé universelle, depuis 6 ans, il y a une réforme majeure que le Burkina a prise, c'est de faire en sorte que toutes les femmes et tous les enfants de moins de 5 ans, qui représentent 25% de la population, puissent avoir accès aux services gratuitement sans payer. Et c'est l'État qui paye à la place de ces bénéficiaires à hauteur d'environ 54 millions de dollars par an. C'est une réforme majeure dont la mise en œuvre est confrontée effectivement aujourd'hui avec 2 facteurs majeurs. On a parlé de la pandémie à COVID-19 et il y a aussi le contexte d'insécurité au Burkina qui est marqué surtout par le terrorisme. Nous avons actuellement plus de 1 million de population, 1 500 000 de population déplacée et aujourd'hui, les mesures que le gouvernement a prises pour pouvoir maintenir l'accès aux soins, c'est des mesures qui ont été discutées avec tous les acteurs, que ce soit la société civile, que ce soit les partenaires au développement, que ce soit le secteur privé, de sorte à ce que nous avons pu, on dit que la traduction en anglais ne marche pas, je ne sais pas trop. Je continue ou bien je laisse régler la traduction en anglais.
Hello? Can everyone
Hello,
Yes.
I think that translation into English is not working. Can I continue or to...
I think it's working now. I see a message saying that it's working. So you can move on, Dr. Yamago.
OK. OK, thank you. Donc, je disais que pour les mesures qui sont prises, c'est avec la participation des acteurs de la société civile, les partenaires, le secteur privé. Alors, ici, je ne vais pas insister sur ce qui a été déjà dit par les panélistes précédents, ce que les ONG font, ce que le gouvernement fait. Et je voudrais simplement préciser 3 points clés. Le premier point, c'est que le leadership au niveau du gouvernement est affirmé depuis plus de 5 ans, de sorte à ce que nous arrivons progressivement à aligner tous les partenaires aux priorités. Dans le contexte de COVID, le plan de riposte, nous avons fait la cartographie avec l'appui des ONG pour dire voilà ce que nous avons, voilà ce que nous devrions pouvoir faire, voici les gaps et les différents partenaires s'inscrivent dans cette dynamique pour pouvoir accompagner le gouvernement dans la mise en œuvre de ses priorités. Le deuxième point majeur que je voulais souligner concerne surtout la partie redevabilité, transparence pour la bonne gouvernance. À cet effet, le Burkina a une tradition dans cette séparation de fonctions qui fait que tout ce qui concerne l'effectivité des réformes, c'est confié au niveau des ONG qui font le suivi, le contrôle et qui établissent, par exemple, le niveau de satisfaction des bénéficiaires. Je peux vous montrer, par exemple, cette figure qui vous donne, en fait, les enquêtes de satisfaction des bénéficiaires par rapport à tout ce qui concerne la gratuité des soins. En matière d'attente, on se rend compte que les populations sont satisfaites à peu près à plus de 90%. Cela montre que le gouvernement au niveau du Burkina Faso ne travaille pas seul, mais il confie un certain nombre de points, un certain nombre d'activités aux différentes ONG pour que ces différentes ONG-là puissent effectivement dire, voilà ce que nous avons sur le terrain comme effectivité, comme régularité, et ensemble nous corrigeons. Le dernier point que nous avons introduit tout récemment, c'est quand on veut ne laisser personne, la santé de personne de côté, il faut investir également dans certaines interventions qui ne sont pas faciles. Je prends par exemple l'accès à la contraception, l'accès aux soins d'avortement complet. Et à cet effet, nous avons pu confier vraiment la mise en œuvre de cette réforme-là avec 3 ONG que nous avons sélectionnées. C'est l'ONG Jipaigo, Pathfinder et Engender Health qui nous aident à rendre disponible un certain nombre de services Et ces services sont surtout axés sur tout ce qui concerne un environnement favorable à l'accès aux droits en santé sexuelle et reproductive et aussi tout ce qui concerne l'assistance technique pour que les formations sanitaires puissent rendre disponibles des soins de qualité accès à toutes celles qui en ont besoin. Vous vous rappelez toujours que les avortements non sécurisés, il y a une forte liaison entre les décès liés à ces avortements et à la réduction de la mortalité. Si nous arrivons à réduire ou à faire en sorte que les soins d'avortement complets soient sécurisés, nous allons impacter sur vraiment la mortalité maternelle. Donc, pour terminer, pour ce qui concerne l'engagement du gouvernement aux côtés de la société civile, nous avons vraiment un dispositif de travail avec tous les acteurs. Il y a des acteurs de la société civile qui sont spécialisés dans l'éducation, dans la promotion, dans comment faire en sorte qu'on puisse atteindre les familles pour que ce soit, par exemple, des familles modèles. Il y a des ONG qui sont spécialisées surtout dans des maladies spécifiques comme le VIH, la tuberculose, ainsi de suite, et qui veillent à ce niveau. Et il y a aussi des ONG qui sont beaucoup plus spécialisées sur le suivi des politiques et des réformes. Si le gouvernement dit ça, eux, ils notent et nous contractons avec ces ONG-là pour que nous puissions aller de l'avant. Donc, cette séparation des fonctions, c'est une réalité depuis 6 ans et que c'est une bonne pratique parce que ça nous permet ensemble de pouvoir avoir des résultats et de corriger les imperfections. Donc, voilà en gros ce que je voulais dire par rapport à l'implication de la société civile et par rapport aux réformes qui sont en cours. J'allais oublier le côté mobilisation des ressources. Et ça aussi, c'est capital, que ce soit la mobilisation des ressources au niveau international, comme par exemple la lutte contre Covid. Nous avons la plateforme CCM, Country Coordinating Mechanism, où la société civile participe aux côtés du gouvernement pour pouvoir lever les ressources auprès du Fonds mondial. Nous avons eu 12 millions de dollars en 2020 et 53 millions de dollars en 2021. Nous avons également d'autres fondations qui, à travers les acteurs de la société civile, appuient le gouvernement. Je peux citer par exemple la Fondation Gate qui appuie beaucoup d'organisations de la société civile, mais le leadership revient au ministère de la Santé d'orienter là où les acteurs devraient pouvoir intervenir, qu'est-ce qu'ils doivent faire en complément à ce que le gouvernement fait. Merci bien, madame.
Thank you. Thank you for highlighting the role. Hi, can you hear me? Thank you so much, Dr. Pear, for your thoughtful remarks and for highlighting government accountability and the role of CSOs on partnerships with the government and accountability. My next panelist is Dr. Akhtar Rasheed. Dr. Akhtar Rasheed had been heading the IRMNCH in the province of Punjab in Pakistan, and now he is the technical advisor to the Minister of Health in Punjab. Just to give you some perspective, if Punjab was a country, it would be the 16th most populous country in the world. Dr. Akhtar Rasheed, could you please confirm if you can hear me?
Yes, I can hear you.
Thank you so much. It's a pleasure to have you on this panel. Dr. Akhtar Rasheed, my question to you is very similar. Pakistan has now, kicked off its process to align its health systems towards the universal health coverage goals and is now making plans and soon going into implementation. Yet we are a country that is recovering, of course, from COVID-19 pandemic as it continues to be there. Our health systems were challenged during COVID-19. And I was hoping if you could talk a little bit about what strategies the government of Punjab have put in place to ensure universal health coverage, and what multi-sectoral platforms are in place to ensure accountability mechanisms are in place. Thank you, sir, and over.
Thank you very much for the Pathfinder for organizing a wonderful webinar. First, I would like to say about, I would like to remember the days which were very hard during the COVID-19. When the COVID-19 started, the pandemic started, this was our health system, which is much robust, which responded well during those days. I would like to elaborate the primary healthcare system. We have basic unit, then we have the rural health centers. This is the primary, and the secondary is above it, is the THQ, the SEAL headquarters, hospitals, secondary care hospitals, and the district headquarters hospital, that is more secondary and less tertiary, and then the less tertiary care hospital. During the days of COVID, our services remains intact because our basic unit, we have more than 2,500 basic unit in a province. Our province is bigger than a country, as you well said, most of the countries. Our basic unit, we have 1,000 basic unit which are providing 24/7 services. 24/7 services means the lady health visitors, means the midwife is present in her duty room. So these systems remains intact and they are providing services. First of all, we responded that we provided PPEs, then the training, and the most of the above of these things is the motivational talks and the motivational system. We elaborated, we placed in it. Due to this system, motivational level, the healthcare providers provided the maternal, newborn, child health, and primary healthcare services, vis-a-vis to the other secondary healthcare services in the area, in the province. We have ambulance system. We have two kinds of ambulance system. One is the 1122, which is the emergency healthcare system. Other is a rural ambulance system. Rural ambulance system is if anybody calls from her home that she needs some help during his pregnancy or natal services, the ambulance immediately reaches to that house and bring the lady to the lady health worker, to the BHU. If there is any complication, then this ambulance moves the patient towards to the next level hospital. The system is always, our system of the primary health care is good. But with the 2030 agenda for sustainable development goal has given the impetus to UHC as an overarching target to guide health system transformation. Now we are in a way to transforming our primary healthcare system, the overall health system to provide UHC coverage. Pakistan is the first country who opted the DCP3 recommendations, and our recommendations are, interventions are, we are opting the intervention at the community level, 59 interventions. At the PHC centers, basic health units and RHC 68 interventions. First level hospital 58, tertiary care hospital 20. It means this is a comprehensive integrated approach to provide the DCP, to approach the universal health coverage. And in response to these interventions, we have developed the essential packages of provincial essential packages according to our local needs. And now we are working with the World Bank in a designing of the two projects. One project we are implementing. That is also a coverage, universal health coverage project. That is to address the poorest of the poor. In Pakistan, there is a card holder. Poorest of the poorest has BISP card holders. They are card holders, and we are providing them services, conditional cash transfer services. Services along with the conditional cash to these people, because they are already, well, because this is the, our indicators are very low in this community, where the poorest and the poorer. These are the two categories where we have very poor indicators of all indicators of the UHC level. So we are targeting first these people. Second is we are approaching another UHC is about family planning. Family planning is an integral component of the UHC, and it is a priority agenda of the government of Punjab in here for the family planning services, FP services. And about $200 million, another project we will be implementing. Another project is about NHSP project, which we are nowadays designing. It is about primary healthcare UHC, not the secondary. It is also a World Bank funded project. If we see the challenges, what challenges we are facing, the challenge is the coverage level. Pakistan is one of the few countries where we are providing free of cost UHC package. All interventions which we are providing is free of cost, whether primary healthcare, whether NCD or communicable or non-communicable disease. These are, we are providing as the primary healthcare, secondary healthcare, tertiary healthcare free of cost. And now the government of Pakistan, the Prime Minister of Pakistan has launched another scheme, is to give the Sehat Sahulat card, insurance card. Everybody will be insured here without paying any premium. The premium will be paid by the government of Pakistan, and everybody will have the right to go to the private sector as well as to the public sector to seek her healthcare. Another, the big challenge is the funding. Now we are approaching the international community like the World Bank, like FCDO, like USAID, all other communities we are approaching, and we are adopting, and we will be implementing UHC. Inshallah, very soon we will have a good indicators. Although the one indicator which we are lagging behind, and we will like to learn the lessons from Bangladesh, is the CPR, which in Pakistan is very low. All other indicators, trajectory is very good. This is all about the story of Pakistan and our measures which we are taking. Thank you very much.
Thank you, sir. We still have 1 minute. Could you take a little time to also talk about the multi-sectoral interventions that are ongoing in the province of Punjab for universal health coverage, or any plans to do so?
Thank you very much. Thank you for reminding me. Currently, if we see, we are implementing our Reach Every Door campaign. Reach Every Door Red campaign is we are vaccinating for the COVID people. This is a multi-sectoral approach. We adopted multi-sectoral. Within the health sector, within the government sector, education department, health department, population welfare department, agriculture department, irrigation department. All departments are collaborating with the health department. The health department is taking lead, and every day we are reaching the 1 million people to inject them. This is the one example. Other is during the COVID response, we approach all private sectors like NGOs, like international organization. Pathfinder was working with us, UNICEF was working with us, UNFPA was working with us, and all other colleagues, we were working under one umbrella. And this is the way we have learned many things from the COVID response. And the multi-sectoral approach, this approach was basically, it was in the literature, but we learned it from the COVID response, and the RNCOC, National Coordination Committee on COVID, is also a multi-sectoral committee where different sectors are sitting together and guiding and leading. Ultimately, this COVID has given us the lesson to the multi-sectoral. Health is the multi-sectoral approach. Thank you.
Thank you. Thank you for your insightful remarks. And I'm very excited to now welcome our next panelist, Dr. Mercy Onsando. Dr. Mercy is the CEO of Health NGOs Network in Kenya. Dr. Mercy, could you confirm if you can hear me?
Yes, I can hear you quite well. I hope you can see me. Can you hear me?
I can hear you and see you perfectly fine. Welcome again. So, you know, Mercy, we have been talking about partnerships and the role of CSOs. So our national question to you is that how do you see the role of CSOs in coordinating activities of partners and the government in achieving universal health coverage in the nation of Kenya? And how are you working to ensure that there's an accountability mechanism around the UHC commitments? Thank you, and over.
Thank you very much. Allow me to start by very briefly introducing Health NGOs Network, or HENET. We are an umbrella organization of health civil society organizations in Kenya, and we were founded in the year 2007. Our vision is actually a health and empowered Kenyan society, and we were formed because there was a felt need that came to the civil society, that they felt there was need to have the civil society well coordinated, able to engage meaningfully, and able to speak in a united voice. By the time the organization was registered, it had only 7 members, but at the moment, we are talking of an organization that has over 101 member organizations in Kenya. May I also very proudly just say that I'm happy to be in this particular meeting where Pathfinder is actually hosting, bearing in mind that Health NGOs Network, one of the founders was Pathfinder International. And the truth be told is that Pathfinder has continued to support HENET in terms of technical support and guidance all through. We do appreciate that great role that was played by Pathfinder 10 years ago, and they have continued to support this very critical structure. Allow me to go straight to the question that you have put before me, and that is to talk about the role of CSOs in coordinating activities of partners and government in achieving UHC in the nation of Kenya. Let me start by saying that immediately UHC was declared a great journey, and a journey to help the citizens in the world to be able to access universal health coverage. The whole civil society organization did come together and identified their roles so that they could be able to support the journey. But one most important thing that the civil society were very keen to see in place, that they really advocated for, was the stakeholder, a coordination framework that would help them to be able to have coordinated work quite well. And we are happy to report that Kenya has the health sector partnership and coordination framework that runs from 2018 to 2030. And this brings together all the health sector stakeholders. And just to say that HENET is one of the recognized partners of the Ministry of Health in Kenya and sits in these stakeholders partnership coordination framework represented by 6 representatives from the Health Civil Society Organization under the umbrella of HENET, and they were selected in a democratic manner. The civil societies, in coordinating the or supporting the coordination of the activities of partners and the government, have clearly noted that, and we have continued to play the role of a catalytic. We stimulate linkages between the ministry or with the Ministry of Health, the private sector, policymakers, generally parliamentarians, with common vision of ensuring that UAT is being achieved. So we do find ourselves in most times bringing together the stakeholders to discuss critical issues that face our country as we walk through this journey of universal healthcare coverage. Indeed, I would say that the civil societies in Kenya have actually, through HENET, set up a very good structure that makes it possible for the donors, for the private sector, and for the Ministry of Health to engage with the civil society organizations. As civil society organizations, and in this framework that we are talking about, the health, the Kenya Health Coordination Framework, we do have specific roles that we expected to play, that we play quite well. And one of the roles is actually to represent the voice of the civil society and to amplify the voice of the community as we advocate to ensure that universal healthcare coverage is benefiting the citizens as it ought to. Sitting in this framework, we also participate and coordinate ourselves as civil society organizations, making sure that we put together what we feel would highly influence and inform the policies and guidelines in our country for effectiveness of making sure that UAT is achieved quite well. In coordinating the partners and the government achieving the UAT in our country, we have this as civil society also brought together the stakeholders to discuss challenging issues, or even to bring together the partners or the stakeholders in the health sector in terms of stalemate. We've had ourselves sometimes with very difficult situations, be they human resource for health strikes, be they stock out. And as the civil society organization, we normally take swift steps to ensure that the different stakeholders are able to engage and be able to come up with an agreement or agree on how to sort out those problems so that our people don't suffer from the lack of proper UAT services. Let me say in this coordination, the civil society also play a critical role of building capacity and sensitizing the citizens. We learned this during the pilot. When the pilot of UAT was done in our country, we did note that the government and other stakeholders were looking upon the civil society to empower and to sensitize the citizens. We did a survey, and we therefore realized this is a critical role that as civil society, we are expected to play. In this coordination, we also generate evidence that is used to inform the policies, the guidelines, and even lead us as we do our advocacy work. So indeed, we make sure that we are able to see to it that we are avoiding duplication, and at the same time, we are aligning ourselves to the output and the results that are expected within the UAT agenda, and in particular, to ensure that no one is left behind. Now, moving to the next question that is very critical, and that because one of the things that the civil societies in Kenya identified as their key role is promotion of mutual accountability, is the question you've asked how the civil society are working to ensure that there's accountability mechanism around the UAT commitment. As I said from the beginning, is that we do recognize that we are very critical, and we normally play a catalytic role, bringing all the stakeholders together so that we can discuss critical issues. We've continued to do that. We continue to bring together the media, the donors, the Ministry of Health, the parliamentarians, the civil society, and faith-based organization. And we found this very, very useful because when we meet, we discuss, and we're able to say, these are the issues that we are going to, or we see needs to be addressed. In regards to ensuring that there is a proper accountability mechanism, health civil society organizations under the umbrella of HENET have been very active in that we have already established what we are calling accountability CSO alliances from the national to the county levels. And these alliances are basically formed by the civil society and private sectors, and with the intention of ensuring that we have dialogue and discussions around the UHC and the component of accountability. We have even identified and engaged social accountability champions who actually look at the gaps and the issues that we need to look into for effective accountability work. May I also say that we are now at the top gear of advocating for the finalization of our accountability framework in our country. This is very key to us, and we believe that it's going to give us a great path that will help us to have better accountability mechanism, allowed UT commitment. We've known that meaningful engagement is key, advocacy important, and evidence generation is very important for effective accountability work to happen in any country. We've kept on keeping the UHC momentum, including coordinating the UHC Day in our country, of which our most recent we did on 10th of December this year. So generally, the civil society have been playing their role of coordinating the activities, and at the same time, and looking into it that we have a proper accountability mechanism. Thank you.
Thank you, Dr. Mercy. Thank you so much. What an exciting conversation and much needed. Thank you. And now I would like to invite our next honorable panelist, who is Dr. Olumide Okunola, the Senior Health Specialist with the World Bank Group, Nigeria Country Office. Dr. Okunola, could you confirm if you can hear me?
Yes, I can hear you.
Excellent. Thank you and welcome, sir. Health financing is key to enabling progress towards universal health coverage. What role has the Ministry of Budget and Finance and the private sector been playing in ensuring that countries invest public resources towards achieving universal health coverage? Over to you, sir.
Thank you very much for having me. Please do confirm that you can hear me loud and clear.
We can hear you, sir. Thank you.
Okay, thank you. So just to contribute to several of the excellent points that's been made by colleagues on this call, I would just like to reiterate a couple of points. Some of them been made earlier. And the first is that as it stands, for those countries that have made the greatest advancements towards universal health coverage, they have been able to do so with public financing or general revenues. In fact, I will put that as a known in the UHC box. But if we then say that public financing or general revenues is our best bet towards the achievement or towards fast-tracking our movement towards universal health coverage, then some colleagues on this call or colleagues at the Ministry of Finance and Budget would then say, that's fine, but where will the money come from? Especially considering what the whole world is going through now in terms of the COVID-19 pandemic, which has now exerted unbearable and almost unbelievable fiscal pressures on several of our governments, but not just our governments, but in fact, one thing I've heard repeatedly on this call is how countries across the world have benefited from resources that have come through external financing. I have news, and that news is not good. Those kind of resources will continue to dwindle and in fact completely disappear. So I will not spend so much time even talking about external financing and things we usually know as donor resources. The pressure then becomes, how do we do to expand that fiscal space? And I do hope that I'm able to share just one or two things as we begin to tackle what I will call a wicked problem. One quick point to mention at this juncture is that despite and in spite of those fiscal pressures, this is not the time to reduce the spending on health. I repeat, this is the time to, in fact, implement what I will call counter-cyclical spending. Usually when countries are in recession or the fiscal pressures, the intuitive thing is to cut spending across sectors, in fact, across in sectors like health. Sadly, in this case, we cannot do so. Countries cannot do so because if the sector does not recover, as is clear to everyone now, the economy will not recover. So it means that counter-cyclical spending must be the norm. So countries that have raised spending as a result of COVID, in fact, need to sustain and perhaps increase that spending, because that's the only way the economy will recover, and that's also the only way we will make gains that we have lost in our journey towards universal health coverage. The next point I would like to make then is that this kind of decisions, unlike pre-pandemic, where the health sector will make its sectoral plans within the sector and then take it to Ministry of Finance and Budget based on an envelope, those days are gone. And I hear loud and clear what the colleague from Punjab just said in terms of the multi-sectoral coordination committee for COVID. Those same, if there's anything we have learned from COVID, it is the use of such multi-sectoral coordination committees. In Nigeria, where I work and live, the Minister of Finance, the DG budget were very much involved and in fact driving some of the COVID-19 response financing conversations. That needs to go, that needs to be maintained or sustained going forward, because maintaining the level of spending that we're seeing now and even surpassing it cannot happen if there's no whole of government conversations. And that also means that financing for the health sector does not necessarily have to come in through the Ministry of Health budgets. A good example is that of subsidies, which we've had on this call as well. Because for instance, for countries that have been able to implement a robust targeting mechanism where the poor and vulnerable have been identified, where, for instance, those same households are benefiting from conditional cash transfers, for example, it means that the health sector can leverage such programs to either expand services or deliver services. And just to also very quickly mention that this is also an opportunity for the sector to begin to contribute to the baking of the cake. There's no better time to institute conversations around what we call pro-health taxes. In this regard, I'm talking about taxes on alcohol, on tobacco, on sugar-sweetened beverages. For instance, in Nigeria, in fact, there are presently no taxes on sugar-sweetened beverages. And we can learn from the example of South Africa that recently introduced taxes, sugar-sweetened beverage taxes. We can learn on how the Philippines was able to use those same taxes to expand the fiscal space and also fast-track its journey towards universal health coverage. Now is the time to have such conversations. Let's make use of this crisis as an opportunity to expand the fiscal space. But that discussion is even in two parts. So whilst it can help to expand the fiscal space, there's also another opportunity. We can also make a case for earmarking for the health sector, because we know that these health damaging products in the first instance have a consequential impact on the health sector anyway, in terms of non-communicable diseases spanning from cancer to cardiac diseases, obesity, and all such things. The health sector will be the ultimate sector that will have to manage the crisis that will emanate from the consumption of such products. So I will strongly urge colleagues to either institutionalize or begin the advocacy to institutionalize pro-health taxes. The last very quick point I would like to make it has to do with reforms around public financial management. Very clearly, we've seen now that public sector providers alone cannot deliver services. We have to begin to also purchase services from the private sector. But then the PFM rules across several of our countries does not necessarily allow for the transfer of funds to such kind of providers. So there's a need to begin to unpack the PFM box. There's several things around this. And the role of civil society in ensuring that budgets are well implemented and are also fit for purpose, and that actors are accountable for such processes is very key. I take that as a cue to stop. I yield back to you. Thank you.
Thank you. May I please request everybody to mute yourself unless you're speaking. And thank you so much, Dr. Okunola. You've given us so many good insights, about this is not the time to cut back on health financing, and we need to bake this cake together. And the last point that Dr. Okunola made about the importance of the private sector, it gives us just the right segue to actually introduce my next panelist, who is Mr. Mizan Rahman. Mizan Rahman is the Deputy General Manager, Marketing for Incepta Pharmaceuticals in Bangladesh. Mizan, could you please confirm if you can hear me?
Yes, Tabinda, I can hear you. Thank you very much.
Yes, thank you, and welcome to the panel. And my question to you, Mizan, is that what role has the private sector, specifically in your organization, played in supporting the government of Bangladesh towards achieving universal health coverage? Thank you.
Thank you, Tabinda, and good afternoon or good morning or good evening, everybody. So as my question is to the private sector, I am representing from a pharmaceuticals company in Bangladesh. It's Incepta Pharmaceuticals. It's not a very old company. We established here in just 21 years back. So our experience is not that much as our pharmaceutical history is a long history, but we are playing some important roles, though we are very young, because now we are one of the second largest company here in Bangladesh. So to the specific points from the private sector or pharmaceuticals, we are providing some important inputs to help government to get the universal health coverage goal. So the first point is one of the three pillars, as you know, in the universal health coverage, along with the health infrastructure, two other important pillars or the points is access to the quality medicine. I mean, the availability as well as the affordability. And another one is patient awareness and empowering the patients on their health choices. So we particularly from INSEPTA is trying to work with the government, particularly with these 2 points, to the access to the quality medicine and as well as to help patients for create the awareness and empower them to own their health choices. So I can just quote this from our experience from the last 1.5 years or last almost 2 years as a COVID situation. So that when we were all overwhelmed by this particular pandemic, we from the INSEPTA particularly focused that what are the challenges that would be coming very soon to help our people, to help our patients, as well as our doctors, as a whole, the government. So we always try to keep the available, all the medicines, starting from the supplements to the life-saving antibiotics and all the life-saving drugs in the hospitals and in the pharmacy, even at the remotest area. So that gave the government a very good way to handle the pandemic. Along with this, we also create some awareness programs when we little bit stable with the situation. We got a lot of experiences along with the other healthcare sectors. So we promoted a lot of things with the government to create the awareness for the patients. So not only this pandemic, in everywhere, our effort is to help patients to access the affordable and the quality medicines, as well as to promote the health awareness issues along with the government. So, I mean, this pandemic has taught us, give us a new way of handling the crisis moments. But as a whole, we have a very good infrastructure of doing this along with the government. So our effort will be continued, and hopefully together we can ensure that we are achieving this goal of universal health coverage. So thank you, Tabinda. That's all from my side.
Thank you so much, Mazan. That was crisp and very impactful. We are now going to proceed to the question and answer session. We have more than 20 minutes for it, which is good. And I just wanted to say here that anybody who wants to say out a question, please feel free to type it in the chat just in case we don't get time to have other people come on board. I already have... Thank you. Thank you, participants. Could you please mute yourself while you're not talking? Thank you so much about that. I've already received some very interesting questions that have started coming in. And the first question is to our country director in Nigeria, Amina. Amina, this question is specifically for Nigeria, and I'm going to read it out to you now. It says, how do the, it says, Dr. Amina, can you explain more how the local CSOs can ask for accountability and how this can contribute for UHC in Nigeria? Dr. Amina, if you're online, please go ahead.
Thank you, Tabinda, and thank you for the question. So I think, first of all, we have a very strong civil society groups in Nigeria. And if they are well supported through, for example, trainings or building their capacity to understand universal health coverage, to even understand the processes, they are able to really have an impact on decision making. So for Pathfinder in Nigeria, we have, as I said earlier, the Advanced Family Planning Project, where we have the opportunity of training a group of civil society organizations that we term as advocates. We use what we call smart advocacy. to train them on how to do effective advocacy, to understand even the objectives of their advocacy, and then take processes in a way that they can reach out to decision makers that, for instance, have a very important role to play in whatever advocacy objective, and in this case, universal health coverage. So if they're well trained, they have networks within them. They can use the media, for instance, for advocacy to bring out stories of change, to let the decision makers know what is going on and what actions they need to take. And they also are able to reach them through going to the national or state assembly to be able to talk to those policymakers that are that we have voted to be able to make decisions for us. So one thing is when they have that strength of power of being together, of a platform, and they are well supported to understand the issues and to follow the decision makers in whatever they do. Thank you.
Thank you. Thank you, Dr. Amina. I have two questions here, which I'll be combining into one. They both talk about donor funds for organizations that are rural-based or grassroots organizations. And Mercy, may I request you to answer the questions, which is, how do non-government organizations in rural communities raise funding to support primary health care in communities? And once you're done with your answer, I would like to request Dr. Okunola to speak a little bit about it also. Thank you.
Yeah, thank you very much. In Kenya, most of the civil society organizations depend on donor funding. And this has been the way for quite long. And therefore, they raise proposals. However, I do know that they sometimes have some very small membership fee that is gotten from the members of those particular organizations to do their very small aspect of primary health care or awareness raising, but mostly they depend on donor funding. And this is something that has been a challenge to many of them. Thank you.
Thank you so much. So mechanisms are being put in place to seek funding. That's very good. Dr. Okunola, would you like to speak a little bit about this question?
Yes, thank you. Just to emphasize the point I had made earlier, that you now have the same kind of fiscal pressures that we are seeing in our countries is also what is being experienced by countries in the global north. And the example of that is directly from the UK FCDO, which is cutting aid spending from a previous target of 0.7 of their national income to 0.5. This, by the way, has a consequential impact on several of our countries on this call. But it's also the reason why webinars like this are important, because several of our partners on this call, for instance, like civil society groups, now need to begin to ask our governments, in terms of, one, what are the steps being taken in terms of domestic resource mobilization, and two, how are those conversations also leading to prioritizing what matters, and my third point would then be to expand our toolbox to use advocacy in a way that makes a lot of meaning to decision makers. And I give an example of the discussion around demographic transition, which is very useful in mobilizing resources to expand services. Because without moving fast on making progress on demographic transition, the kind of economic growth that's seen in some of our countries might not be possible. So such kind of articulating such kind of concepts would allow us, policymakers to prioritize the financing for services. How, however, some of this financing would translate to organizations that are working in hard to reach locations is something that we will certainly need to have to give more thoughts, because our governments do not necessarily work in such a nimble, flexible way to contract a CSO to say, look, I need to expand services. But it's something that I think must be brought to the table. Thank you.
Thank you so much. And now I come to the two government representatives on the panel, Dr. Pia and Dr. Akhtar Rasheed. I have one question, which is both for Burkina and for Pakistan, which is, we talked about multi-sectoral partnerships, and we also talked about the role of communities and CSOs. And one of the questions we have is that how can the multi-sectoral partnerships work under one umbrella to unify their work, to reduce duplication of work, to report on the progress? So for example, we have a lot of multi-sectoral platforms for different activities, which are sometimes time-bound. But for universal health coverage, are we looking forward to these kind of partnerships under one umbrella? Dr. Pia, may I first request you to come online and answer?
Oui, merci bien pour cette question. Je dois préciser que ça fait une année que nous travaillons à mettre en place ce qu'on appelle une cartographie dynamique des intervenants et des ressources, de sorte à ce que nous puissions mettre sur Internet qui fait quoi, quand, où, pour quelle durée et pour quel financement. Que ce soit les ressources de l'État, que ce soit les partenaires, que ce soit les ONG, que ce soit les associations. Nous avons déjà fait la maquette et ce défi, une fois qu'il est mis en place, nous pouvons, au niveau du ministère de la Santé, canaliser et organiser l'intervention vers là où le besoin y est, pour éviter que beaucoup d'acteurs se retrouvent dans des zones de duplication et il y a des zones vides. Ce que je veux déjà dire, c'est un défi que nous sommes en train de mettre en place. Peut-être d'ici une année, ça va finir. Et chacun aura accès et chaque partenaire qui va intervenir, il regarde sur Internet, il a toutes les informations. Deuxième mécanisme qui est un acquis au Burkina, les financements publics qu'on utilise pour soigner gratuitement, le gouvernement réserve à peu près 2 millions de dollars chaque année pour donner aux organisations de la société civile pour aller contrôler, suivre et puis rapporter vraiment si c'est effectif. Et c'est quelque chose qu'il faut soutenir et puis élargir à d'autres services. Et nous sommes dans cette réflexion pour que, quelle que soit l'origine du financement, que ce soit de l'argent domestique ou bien de l'argent qui vient des partenaires, c'est le ministère de la Santé qui doit être au centre des décisions pour pouvoir dire, voilà, telle ONG, tu vas faire ça, ça, lui, il va faire ça, ça. Et nous sommes dans cette réflexion. Merci.
Thank you. Dr. Akhtar Rasheed, may I request you to not take more than 1 to 2 minutes to answer the same question?
Thank you, Dr. Tabinda. What we learned is that first I would like to say the partnership. Partnership within the sector, partnership beyond the sector. Partnership within the sector is that kind of partnership which is the partner which are working in the health sector but not working in the public sector. They are from the private sector, like they are from the NGO sector, like they are from the UN sector. Everyone has its own capabilities and capacities, and we will work with them with clear roles and responsibilities, assigning them, and then we can work together. Other is the partnership with other sectors, like we have the education department, the education sector, like we have the public sectors of physical and hygiene sector, like we have the sanitation, water and sanitation center. These centers will have their own roles and responsibilities, very clear roles and responsibility, and for achieving the universal health coverage with their partnership and their roles, we will achieve, hopefully we will achieve.
Thank you so much. I do not see any more questions on the chat box. This has been a very insightful conversation. I thank on behalf of Pathfinder all the panelists who took out time. May I now hand this back to Habeeb Salami for his synopsis of the discussions and his closing remarks. Thank you so much.
Thank you very much, Tabinda, for moderating a very powerful session with a lot of inciting information from our panelists. We've heard from the governments of Burkina Faso and Punjab in Pakistan, where they highlighted partnerships with civil society, particularly in the areas of resource mobilization for UHC and accountability in Burkina Faso, and also in Punjab, where the lessons from having a multi-sectoral committee for COVID-19, it's what they want to take forward in terms of achieving UHC. We also heard from civil society organizations with particular reference to Kenya, where civil society have been able to engage government through a partnership coordination framework that allows government, private sector, and civil society organizations to coordinate efforts towards achieving UHC. We've also heard from our health specialist from the World Bank, where he has told us that public financing or general revenue is the key to achieving UHC. However, there needs to be an expansion of that financial space in country, and public-private partnership, cross-sectoral budgeting for health, and conditional cash transfers, others might be the way to go in expanding the fiscal space for health in our countries. And then lastly, we heard from the private sector from Bangladesh, where their focus have been on access to quality medicines and also creating awareness and empowerment of clients on their health choices. I think these have given us opportunity to look through and talk through what are the opportunities within multi-sectoral collaboration towards achieving UHC. We have seen examples that we can take from the different countries and panelists that have shared with us here to our different programs in our countries and supporting government and what governments would do as lead in their countries, particularly in terms of coordination and resource mobilization to help achieve UHC. So I thank you all, particularly our panelists, for sharing your thoughts and ideas with us and experiences that you've been able to put together in your countries. I also want to thank very well participants online, particularly those who have stayed from the beginning till the end of this webinar. It's been an exciting one for us too. And I think I also would need to thank the team in Pathfinder that have been working back end preparing this and giving us the opportunity to have this wonderful conversation. We'll put the notes together for all those who have registered to be part of this. We're going to share with you and what we hope to take forward from this webinar once the notes are put together. I say a very big thank you once again to everyone, and let's continue to provide support to government in the different ways that we work so that we can all achieve universal health coverage in different countries and geographies. Thank you very much, and you have a wonderful rest of your day in where you are. Thank you, and bye-bye.
Thank you.
Bye-bye, everybody.
Bye-bye.
Thank you.
Thank you.
Thank you very much.
Hey, Ashim.